because we're a bit worried about it. It's not.
Can I ask a little question?
Yeah.
In terms of female to male transsexuals, how long has that research been going on? Like medical research and like scientific kind of studies?
I don't really know, but the first time it was kind of really recognised, I guess, was by Harry Benjamin, which was in the 1960s.
Right.
And I think it's only from that time on that people began to realise that it was a real entity. And now we've got data showing that, yes, 1 in 10 to 30, well, what is it, 1 in 30 or 40,000 people across the known world, where the data are published, North and South America, Europe, Southeast Asia, everywhere, the data is just about the same. 1 in 30 to 40,000 suggests that it's really, really a real entity. It's underlying something, it's inherited, you can't fix it, it's not just mad, it's nothing to do with that, it's a real issue. And I think then the issue is what you can do about it, and if you're going to research, how can you get the funding, how can you ever get enough people to mean something?
Enough of a sample.
Enough of a sample. And the trouble is, the real issue is, to get a real sample, you have to force everybody you meet to be treated in exactly the same way.
And everyone's different.
Everyone is different, everyone wants something different, and either you go like they do in Holland and say, no, you come here, we'll treat you, but you're getting this. It's not a supermarket, we're going to give you this, that's it, no argument, you're out, or this is what you get. And they have the only data that we have. And then, of course, after all these years, all we can say is this is the data for that specific treatment. And the answer is we're always living in a kind of controlled uncertainty, or less than controlled uncertainty, and that's how we have to operate. We'd love to have data, have really high quality data, and then we can say, look, this is this.
Different,
Fascinating.
It is.
Is it true that testosterone enhances qualities that are considered stereotypically male? We've got two really interesting examples here, but shortening of attention span and loving tenderness decreasing.
Loving tenderness decreasing. And being able to find your way from A to B on a map more easily, and that kind of stuff. I don't know. There are anecdotes. I know there are lots of anecdotes that suggest this is the case. And we call anecdata, I think is the way to describe it. I honestly don't know. People say this happens, and and then I was in the car and I just couldn't find my way, on estrogens. I should have found, and I couldn't.
But I can navigate maps easily. You
Can
see,
you?
my mum gets really confused, and so when we were going up to Wolverhampton to see Radiohead, I was like, take this road. No, Mum, take this road. It will be quicker. And she was just like, no, we should go all the way. And I'm like, no, this way. I'm fine with maps. I actually enjoy looking at maps. I like reading maps, just looking at the weird place names and going, oh, that's a funny name.
But that may be you, and it may be the way your mind works, which is maybe how you are, how you feel about yourself, and nothing fundamentally to do with male hormone. I don't think male hormone is what somebody doing the knowledge in London who wants to become a cabbie is going to be shooting themselves up with at night, thinking, well, this will really help, like caffeine for students, and it's not that straightforward.
Nature-nurture argument.
They all nature. Because I'm a very good map reader, I have to say.
Are you? You're bloke deep down.
Yeah, that's it. It's
That's been said.
It's black and white.
right.
It's as simple as that. You're a bloke.
I know people have said to me, I'm in touch with my female side, and I go, what is it? How is that? Does it mean you're not horrid all the time, or what does it mean? It usually means something very partisan.
Yeah.
And it can be used as an insult.
Yeah, maybe that's it.
Or taken as an insult.
Oh yeah, sorry, I thought it was a compliment, but now you put me right. Thanks a bunch. Yeah, okay. It's an insult. As far as the other way, I don't know. I mean, does taking female hormones really screw up your map reading and make you more understanding? I don't know. I really don't know. I mean, I think the gay community have got every spectrum of behaviours of both sexes, and they'll have absolutely normal levels of male hormone, presumably, or female hormone, depending on their genetic sex. So I don't know what the real relationship is between the two. It's very difficult.
And you can get blood tests before any kind of extra hormones that you take. You can get blood tests for a scale from how much estrogen you produce and how much testosterone you produce in any male or female. Is that right?
You can test whatever you want.
Yeah.
Sure, but does it mean anything? I personally don't. I feel very much that it's inappropriate to do these blood tests. It's driven by the law. It's driven by lawyers. It's not driven by common sense. If I get a man who says to me, I'm a woman, and all these psychiatrists agree, can you give me female hormones? I'm not going to test her male hormone levels because it'll be a man. I'm not going to undress her and look at her genitalia because it'll be male. Because why shouldn't it be? There's no real association between intersex disorders, which are outrageously rare, and transsexualism, as far as I know. Of course, we'll never get enough data to show one or the other, but I don't think there's any relationship. So I just assume that what I'm dealing with is a biochemical, endocrinological, gonadal, genetic male who's a woman. And until I start treating with hormones, I don't know what to measure. You know, it doesn't make sense to start jabbing people in. But then some people like measurements. Some people feel as if I'm doing something better. So I try and accommodate them.
If you get a result that's already within you, you might feel more justified for your next action and that kind of thing. Oh, I had this amount of levels, so of course I'm...
It doesn't mean, I don't know what it means.
Yeah,
you know, you get male hormone levels that might be 35 or might be 6, and then there's just as male as each other. You get this little wimpy man with an enormous long phallus, and kind of a real macho man with, of course, nothing, no tackle at all. There's no relationship. So I'll do whatever the patient... I fundamentally don't want to do blood tests. If it's not going to alter what I do, I don't want to do them, really. And if you're going to have to travel from A to B, it doesn't matter if you've got to go. It doesn't matter, So it's... you need a rationale for all of these things. So if I'm going to do a blood test, I can say, okay, now what if the result is this? What will I do? What if the result is that? What will I do? If it makes no difference at all, what am I doing? And I tell our medical students, for example, we teach, that's what I do. You know, we say to them, well, okay, look, imagine that you're getting paid a bit more, but every blood test is coming out of your salary. Okay, it's 20 quid a go, that's what they are. So we can do thousands of pounds worth of tests in the first 10 minutes if we want to. What would you like to do? You know, and then you say, okay, it's 20 quid, right, and then why? And it's very telling. People go, well, actually, maybe we won't do that, and do something more useful. I think in a female to male transit, there's not much I do. I suppose I'd do a DEXA scan, a bone mineral density scan, at some time, because there's a little bit of anxiety about osteoporosis risk. But if you ask me why I'm doing it and what I do, the reality is I shouldn't really do it, because I'm not going to do anything. If it does show osteoporosis developing, I'm not going to begin to treat it until you're about 70. And then I'll step in with some fantastic drugs that we've now got, and it'll be fine. So I don't know why I'm doing it. I think it's because it makes me feel smart. Yeah. You know what I mean? It's kind of like, I really ought to do this to show that I know that there's a risk of it, but really it's not sensible. I should leave you alone. Maybe just do liver function, make sure I'm not poisoning you too much.
Also, there's an argument that just came to me about implanting people with ideas about themselves. I mean, I remember being very young and getting some tests done, and they actually told me something that scared me a lot when I was like 9 or 10, which I didn't need to know until I was in my 20s. And they told me it back then, and went through this whole process of being kind of 18, 19, and realising that what they had told me when I was 9 and 10 had been affecting me for my entire childhood and puberty.
Absolutely.
And was actually a horrifying thing that I didn't need to know at the age of 10, but they told me because they found it out.
Was it relevant?
No, absolutely irrelevant to my upbringing and my young life. And you know, if I had got to the stage where they said, you know, basically when you get to this age and you're in this situation, you're going to need to know that you have this. So tell me when I'm 10, and that won't happen until I'm in my late 20s. You know, and that's what happened. It's like you almost implant someone with an idea or something, and it could possibly develop because they're paranoid about it for 20 years.
I couldn't agree with you more. We're damned whatever we do as doctors. If we don't tell people things, I mean, we try. It's a difficult line to reach. If we don't tell people things, then they will complain.
Angry that you didn't tell.
Yes, and if we do tell them things, it's an assault. And so you just try and approach them in such a way that they feel able to ask you questions. And if they ask you, you tell them. And if they don't ask, you think that they don't want to know. And it's always the way that we practice. We have lots of information about people all the time, about scans and things, which show things that people don't want to know. And we'll be standing there and we'll say, do you understand what's going on there? Are there any questions, anything you'd like to ask? And of course then you end up playing a game. They know exactly what's going on, we know exactly what's going on, but neither wants to admit to the other, which is fine. ignorance actually is bliss, and it can
Yeah.
make you a lot better and more functional and live longer.
Yeah,
So
especially with me. So I'm a total hypochondriac. I always think I'm dying
Do you?
of everything.
Really?
I mean, when I found out about this whole bird flu thing, everyone, bird flu. Oh no, I'm gonna die of bird flu. Every time, a tiny little red mark on my arm. I've got meningitis. I'm gonna die. Yeah, really paranoid.
It's bad,
so,
isn't it?
Yeah.
But then it can be very difficult because doctors, we have a much bigger legal department here than we have nursing department.
Wow.
We have a huge amount of money. We have in this trust, I believe we have something like 400 major complaints going to law at the moment. 400. This trust is probably better than most others. That's not complaints. That's ones going to law. Complaints are just all the time. People arrive complaining. It's what the tabloids tell you to do. Doctors are overpaid. They don't give a toss. And it's really not true. We try ever so hard, but we don't know what we're doing all the time. With the best will in the world, with all of the tests, all of the data, we know we're operating in uncertainty and things are changing all the time. People find it very hard to accept.
And on individuals.
Individuals, absolutely. In ER, all you do is you run in shouting at people, and Bob's your uncle. You can resuscitate them. I think I've seen one person in my career walk out of hospital having been resuscitated.
Wow.
It's dying is a sincere act. I think it may be that the circumstance I'm in, we don't see many electrocutions, and I don't work on coronary care where they might have a rhythm problem, but it's unusual. Mostly ER is a bit synthetic, and people imagine that you can always sort things out. It's like when Ayrton Senna died, the racing driver. People going, why couldn't you rush him to hospital? There was no head there on the body.
And why is saving someone the answer? Saving someone's life the answer?
Yeah.
Sometimes
they just want to die. Can I ask, what's the relationship between hormones, behaviour and environment? It's kind of a sociological question, maybe. I'm not sure. Hormones.
God.
It kind of links to that previous one, doesn't it?
Hormones,
About
behaviour and
personality,
environment.
behaviour and environment, yeah. I mean, maybe just in your anecdotal, experience of treating people.
I don't know. It's an impossible one to answer. I suppose it's the crucial question for a transgender person, for a transsexual. Are you going to be better off in this role? And will you be more comfortable in the long term in your chosen gender role? We can't cure anybody. It's all remedial therapy. It's mutilating. It's long term. It's inescapable. It's irreversible. It would be a catastrophe for somebody who isn't of that mindset. And the whole thing is the answer to that question. I don't know. We here get what I would need now is I need 2 independent opinions from interested and trained psychiatrists in this particular field to confirm the diagnosis for me. And our surgical services here for these people are subcontracted to London, Charing Cross, because you need one surgeon to do this. You need someone with experience. And they get another 2 independent psychiatric opinions. Unbelievable. They don't trust ours. So you end up with 4 independent psychiatrists. I know it's crazy.
Wow.
And I know. I mean, normally these diagnoses are written across your forehead. You don't really need to be the brain of it to know. But we go through a lot of things, and they're all asking the same question: is this person going to be more comfortable in the long term in their chosen gender role? We know what they think, and we know that they think they will be. Is it true? And I don't know I don't know any test of that. There's no test of transsexualism. There's no test of gender dysphoria at all. So it's a tricky one. And if you found the answer to that, or if you manage to deduce it from everything, you'll have more data than anyone else has got with this.
That's what we are planning. Well, I think there's a few of us who are quite excited about the outcome of the project that we're doing and the projects that might come out of it after this, because it's the starting of collection of data, and I know a lot of F2M networks around the world are collecting their own data, and that's probably a lot that can inform maybe the medical practices.
Maybe. I think mostly people get it right, to be honest with you. If you look at Russell Reed's practice in London, I don't know if he saw 5,000 or 7,000 people in his career, and he always started with, his approach was always, this person's telling the truth, they're upfront, they have got what they say they've got, and he was always on that side, not kind of this person needs their tree shaking. They're in the wrong canopy, the wrong tree, in the wrong forest, and they're bonkers, and kind of shaking it till they drop out. And Russell Reed was always the other way round. And his rate of regret, I think, was one of the lowest of all. And I think that it's supposed to be between 3 and 5%, which is horrifyingly high. This is 1 in 20, 1 in 25 of all the people. And his was less than 1%, miles less than 1%.
Wow.
So it's very unusual to get it wrong. And in my career, I won't be able to turn around and give anybody a percent because I won't have seen 100. I don't think. You know,
Right.
I've seen, I don't know, maybe 40 or something, 50. And, you know, we're not super specialists in it. We're just kind of nice. I think, you know, that's the kind of what goes along the drums in the forest. But we're not, you know, we're just gormlessly nice, not really kind of fabulously. Well, maybe I'm being too modest. I know I don't know, and I know it's not known. It's not that I haven't bothered to look. I've tried very hard. You know, when you're a medic, this is what happens. You find a disease and you don't know about it, and this happens on the ward round. Make a note, and you come back to your office and you look it up and you make sure you know about it next time. Did that with transsexualism, and you come back to your office, there's just nothing. There is nothing there. So I think, so you do that a few times and you think, well, this is crazy, I don't know what to do, we don't know what we're doing. So then you try and find someone who knows what they're doing, and all of the trans community who came to see me said, this guy in London's great. So I phoned him up and said, can I come and, because I do a clinic at Queen Square, and I thought, well, can I come and take you to lunch? You know, and because it's not what you want to do. I mean, it sounds partisan and it sounds corrupt or something, but you don't. So taking it, found him, took him to lunch, and he was wonderful. He just opened his amazing Filofax of stuff. You know, of all this is the surgeons, these are the good ones, these are the not so good ones. This is that, this is what you do. All of that stuff, to everything. And I went back kind of clutching all this information. And he actually thought, I have to say, that I was going to set up a private clinic or something. So it was an incredibly generous thing to do. And it wasn't the case at all. I'm just an NHS. I don't do, I belong to the university. I don't do any private practice. I don't think it's not what I would want to do. What I spend my time. But it was wonderful. And then with that, then because I was on the editorial panel of a journal, Clinical Endocrinology, and my field is actually pituitary disease, but I've written a lot of reviews about that and books and stuff. And I thought, well, I know I'll write about this, and that will force me to find out everything there is to know. So I all the literature, there's nothing. You know, it's just amazingly sparse. And then wrote the review saying, this is what we think, this is the data, these are the data that we've got, this is where there are holes, and wrote a review for them. So now I know I can really turn around to you and say, I haven't a clue. Because the data's not there. And, you know, you just think, you go a patient who says, I want this and this and this, and you say, okay, well, that's fine. You've got to remember, this will give you this much risk. If we put you on a progestogen too, it'll add this much risk. If we do this, it'll do this, it'll do this. How do you feel? And, you know, fundamentally, people have to feel better. There's no point in me giving back people hormones at a rate that I think is appropriate, doing blood tests and getting levels which I think might be appropriate, and the patient says, I still feel ghastly. I mean, they've got to feel better, the whole point. Otherwise, it's just poisoning. Now, I might as well make them feel better and then poison them. See what I mean? There's no point in just giving them the risk with no benefit, because that's all risk. You have to weigh it up, and it's difficult. And you know, when I'm in court, you know, then you think, okay, well, I can't do that anymore. I'll be struck off if I get an opportunity to. But you do your best with the data that you have. But there are people out there who very much believe this and feel that everybody else is not doing the right thing and they're acting inappropriately, and that's very difficult for us, because you have to fall in line, because the law at the moment would find you guilty if you find 2 or 3 people who think that you are acting inappropriately.
Wow.
So that's how medical law works at the moment. So it's difficult to
Very.
Would it be how likely would it be that someone would become dependent on hormones? Like if they've been taking them for a long time and they became unavailable to you, what would you do? Would you become ill if you couldn't
have them? That's a very good question. You wouldn't become ill. I mean, I think that you just stop them. The changes that you'd seen would begin to regress a little bit. Not all of them, but they would regress a little bit. You know, breast development would get less if you're male to female and so on and so forth. And you would be at risk of osteoporosis. So we would need to get some hormone back into you. But we're never without these hormones.
Mm.
I think for a short time Organon had real trouble making their mixture of testosterone esters that they put in Sustanon, and we were running low on the implants and things, but it's okay now, and it's really, the pharmaceutical industry are very good like that. They're really, the regulation around them is such that they really can't just run out.
Can I just ask a quick question
Yeah,
in
of
there
course,
about
please.
hysterectomies? If you had a hysterectomy, then you would, I presume, be dependent on injecting some kind of hormone.
And an
Taking
ovariectomy. The hysterectomy wouldn't do it. If you had your ovaries removed as well, which maybe you mean an ovariectomy, then absolutely, you'd have no hormones at all. You would be postmenopausal instantly and have rampant osteoporosis as well as hot flushes and feeling generally pretty awful.
You weren't taking your testosterone.
If you weren't
for the rest of your
taking,
life.
absolutely.
But
Absolutely.
if you just had a hysterectomy, you'd be all right, because it wouldn't. Well, you still have ovaries. So.
If you left the ovaries in, then presumably if you were taking male hormone and you stopped, the ovaries would begin to pick up again. But they may not do. I mean, there's a slight worry that you're making them polycystic or something.
What does that mean? Just not working?
No, there's a condition called polycystic ovarian disease, which we see very, very commonly, PCOS or PCOD. It used to be called Stein-Leventhal when it was very developed, and it's very, very common in women, and it causes, reduced fertility and a bit of hair growth, hirsutism, and reduced number of periods a year. And it's quite a complicated problem, but it's a very common cause of irregular and reduced frequency of periods and things. And there's a worry that you might kind of induce that change with exogenous androgens by giving people injections of androgens. Polycystic. Lots of cysts in the ovaries. It's like half, but the follicles, ovaries are cystic, that's how they work. You lay eggs by developing little cysts, which are little follicles. One becomes dominant, develops fully, and you lay the egg, if you see what I mean. And in polycystic disease, lots of them develop simultaneously, but not one of them doesn't become dominant, and so you end up with a little ring of follicles, polycystic, multiple cysts in the ovaries.
Right.
And there's a worry that it might cause that, but there's no evidence, I don't think.
Can I just ask a question then? Because I know that in the kind of like the FTM kind of journey of transition, if you like, there's a lot of discussion about whether a hysterectomy is and taking your ovaries out, I don't know what the term is part of that. Yeah, and I think there's a lot of debate about it. So are you saying then that if you take out the ovaries, then you're not producing any estrogen and you're taking testosterone, that there's a risk of osteoporosis? Is that a possibility?
It is possible. I think we believe that the testosterone will protect you, but we still don't have very good long-term data about that. But if it did cause that, we could deal with it.
Right.
Osteoporosis is not a problem. We've got wonderful, wonderful drugs now that we can use which are not estrogenic or anything like that.
Oh, really?
No problem. As long as we recognise it, we can deal with it.
Right.
Yeah.
Right.
But it's a very good question. If you're asking, do you need to have ovaries and a hysterectomy with all of that entails, that's a very good question. And my answer to that would have been, there's no evidence. But this paper that I've just reviewed suggests that even with high levels of male hormone being injected, your ovaries are still producing estrogen. Now, if your ovaries still produce estrogen to some degree, that means that estrogen responsive tissues, particularly the lining of the womb, the endometrium, will still be thickened, and it's still stimulating it to grow, and your risk of endometrial cancer will still be raised.
Yeah.
And this was the dogma that, within 2 or 3 years of starting androgen treatment in a female to male trans man, you had to have a hysterectomy and a bilateral oophorectomy. And I was always of the opinion, well, where's the evidence? Did you have to do that assault? And this was a little bit of evidence, if you believe it.
Yeah.
No, do you believe that?
I don't believe. What I'm saying is, I would want to have a hysterectomy, but I'm not saying that. I'm not saying you have to. I'm saying that personally, I would personally want to, but that's my personal choice.
Yes, I mean, I think if you've got organs in you which are then redundant in the long term and which are associated with a significant cancer risk in anybody, then you think, well,
what's the point? And
what's
I
the
don't
point?
want it anyway.
But the point really is, you've got to consider, we kill some people just by operating on them. You can have a pimple off your nose under general anaesthetic, you can die. You've got a risk of about 1 in 5,000. That won't help you live a full and happy life in your chosen gender role if you're dead. And you have to think about the risks of all of these things, and it's a real operation, and it's just you've got to consider the things. And also, you take out these things, you leave the top of the vagina unsupported. And that can prolapse then, because normally the vagina, obviously the uterus is with it, and you've got special ligaments that go across to support all these structures in the pelvis. The urethra, the outflow of the bladder, which you pee through, is actually in the front wall of the vagina there. And if the vagina is not supported, the urethra isn't, the integrity of you're not, well, incontinence can happen. It's a little bit more likely. So there are problems. You can't go and kind of whisk out everything you think might be redundant and, you know, be absolutely intact. It has to be, you have to know the benefits and the risks.
Yeah.
And you have to get the right person to do it for you. You need the best surgeon. All surgeons are not the same. Like all doctors are not the same. It's like a plumber, it's like a car mechanic. You get good ones and bad ones, you get experienced ones, you get naff ones. You know, if you've just learned to drive and you're for the first time ever in a car on your own, you may not be quite as good if you have a passenger as you would be if you were 20 years hence and you had 20 years driving experience. You've got the same qualifications, remember. It's the same with surgery. You need people who are just fantastic with their hands. We don't know quite what it is in a surgeon's hands. Some are good, some aren't. Same with all of us.
I think